All right, in this video we will be discussing about another topic of neurology, that is numbness, tingling and sensory loss. This is again read under the topic of symptomatology of neurology. Symptomatology of neurology. Right, we are basically reading about the symptoms of neurology, neurological symptoms. The symptoms with which a patient presents to the OPD which pertain to the central nervous or peripheral nervous system, right? This is numbness, tingling and sensory loss. This is the name of the chapter, right? I am teaching all these chapters straight from the Harrison. These all chapters are written in the Harrison. I am just noting down the important points in those chapters and dictating it to you, so that when you read you read those chapters, it is quite easy for you at that time, right? So this chapter is basically numbness, tingling and sensory loss. The chapter number is 25. Chapter number 25 in Harrison's 21st edition. 21st edition, right? Okay, now coming on to the main topic. I mean, coming on to the gist of the topic. First heading is positive and negative symptoms. I mean, the chapter is started with the perception of symptoms, how the patient perceives the symptoms, and we divide the perception into two types, that is positive and negative. Either the patient will tell something, that he is feeling something, some pain, some itching, some bend like sensation, tightening like sensation, or tingling sensation. Tingling means pins and needles, very common, very commonly the patient will come to the OPD and tell you that there are pins and pricking type of sensation that I can feel in my feet, that I can feel in my hands. There is like something crawling in my hands. So these are basically the positive symptoms, that the patient is able to tell something, that something is happening with my body. At the same time, there are negative symptoms. Negative symptoms, the patient cannot feel the stimulus. For example, if you touch the patient is not able to tell that you touched the patient, right? So this is a negative phenomena. Negative phenomena is nothing but numbness. Numbness is a negative phenomena. Otherwise all these are the positive symptoms, right? I have prepared this PPT. I can share the link with you of this PPT. You can download the PPT and read it later on. So the prototypical positive symptom is tingling and prototypical negative symptom is numbness, right? Now these are the positive and negative symptoms. Coming on to the next slide, it is basically about the terminology. There are a few terms which we use when we examine a patient of neurology or examine a patient of sensory loss, right? First is the paraesthesia. Paraesthesia means tingling or pins and needle sensations, right? Tingling, pins, needle sensations means it is not normal sensation, it is paranormal sensation. Paranormal sensation means it is not aesthesia, it is paresthesia, something related to aesthesia but not means not typical sensation. It is tingling, pins, needle sensation. Dysesthesia, dis means pain, right? Pain including painful ones. Dysesthesia means painful sensation. Paresthesia does not include pain. Does not include pain, but dysesthesia includes pain, including painful ones, right? Hyperesthesia or hypoesthesia, reduction of cutaneous sensation to a specific type of testing such as pressure, light touch, warm or cold stimuli. Means I will apply this stimuli and the patient will not be able to appreciate these stimuli, means there is hypoesthesia. Means the patient will able to, but he will perceive less intensity of these symptoms. This is hyperesthesia. Another is anesthesia. Anesthesia means complete absence of sensation. Hypalgesia or analgesia means reduced or absent pain perception. That is only pertaining to pain. Hyperesthesia was related to any kind of stimulus, but hypalgesia or analgesia means only pain. The pain is perceived to a lesser intensity. Hyperesthesia means increased sensitivity in response to touch. You touch the patient very slightly and he will complain of pain, that, oh, I am going to die with this pain. Allodynia means I am applying some other stimulus and the patient is perceiving another stimulus. For example, if I am simply touching the patient on his hand or feet, he will complain of pain, that I am feeling pain by simple touch. This is allodynia. The stimulus is something else and the perception is something else. Hyperalgesia means the stimulus is painful but not that painful, but the patient perceives it to be very much painful. It is hyperalgesia. Hyperpathia is a broad term which encompasses all the phenomena described by hyperesthesia, allodynia, hyperalgesia. Right? Hyperesthesia, allodynia, and hyperalgesia. Right? These three, these three sensations, these three symptoms, they come under the topic of hyperpathia. They are known as hyperpathia. So this is all about remembering the terminology. It is very interesting and very important to know, very useful. Now, anatomy of sensation. It is something quite related to the anatomy. Means there are the sensory system starts from the peripheral receptors, then the nerves which carry those sensations to the spinal cord, then from spinal cord to the medulla to thalamus to cortex. So all these pathways, they are connected in a certain fashion in order for the pain to travel from periphery to the central nervous system. So starting with the receptors, first is the nociceptor. Nociceptor means which responds to tissue damaging stimulus. It will produce pain, means they generate pain. Thermoreceptors, naked nerve endings. These are naked nerve endings. It is asked many a times in the exams. It is naked nerve endings which respond to non-injurious thermal stimulus. Non-injurious but thermal stimulus means basically warm stimulus. Then the mechanoreceptors. Mechanoreceptors are encapsulated terminals. Again, it is asked in the exams. Encapsulated terminals which are activated by physical deformation of the skin or stretch muscles. Afferent peripheral nerve fibers conveying somatosensory information from the limbs and trunk traverse the dorsal roots and enter the dorsal horn of the spinal cord. The cell bodies of the first order neurons are located in the dorsal root ganglion. In an analogous fashion, sensations from the face and head are conveyed through the trigeminal system. Right? It is very simple to understand, but it will be very easy if there is a diagram. Let me see if there is a diagram. Yes, there is an image. It is said that uh, these are the dorsal root ganglion cells, right? DRG cells. DRG cells are the first order neurons. These are the neurons. Their one axon is going to the periphery. Periphery means receptor. It is connected to the receptor, and the other axon is relaying in the spinal cord, right? And important part is here is that this is the spinothalamic tract, STT. This axon will cross to the opposite side at the same level, right? It will cross to the opposite side at the same level. This is the root entry, and at the same level the neuron, this is the second order neuron, this is the first order neuron. The second order neuron will cross to the opposite side at the same level, and it will go up to the ventroposterolateral thalamus. Let me see if there is VPL thalamus. Yes, it is there is VPL thalamus. This is the ventroposterolateral nucleus of thalamus. Ventroposterolateral nucleus of thalamus, right? Let me zoom out a little so that you can see uh, from where the nerves are traveling. From the periphery, they will relay in the spinal cord. From there they will cross to the opposite side at the same level. Then this neuron will travel up to the thalamus, I mean passing through whole of the spinal cord, through the medulla, through the pons, then to the from to the midbrain, then to the then to the ventroposterolateral nucleus of thalamus. From thalamus, there will be projections to the um, post-central gyrus for different areas. Like there is a different area for arm, different area for leg, different area for face, different area for trunk. All these areas are distributed in the post-central gyrus, and these axons are distributed alongside, right? And now we were discussing this anatomy of sensation. This is what I have just explained in that diagram. In an analogous fashion, sensations from the face and head are conveyed through the trigeminal system. Like I have just explained that how the stimulus is carried from the periphery via the spinal cord. I mean, the limbs, the trunk, the limbs, hand, feet, the stimulus from these locations are carried through the spinal cord. In a similar fashion, the sensations from the face, they are carried via the trigeminal nervous system. I will discuss this in detail when I will be discussing on the trigeminal nerve specially. Right, it requires a different lecture in itself because it is a very extensive kind of topic, because there are different nuclei of trigeminal system and all that stuff. So but as far as you have to remember the things, you must understand that there are two analogous systems working. One is the spinal cord, right, and one is the trigeminal system. The stimulus from the face is carried by the trigeminal system, and stimulus from the limbs and the trunk is carried by the spinal cord or the dorsal root ganglions or the peripheral nerves, right, from that part to the via those nerves to the spinal cord, and then as I have just explained in the previous slide, right. So this is all about remembering the pathway of pain. Now there are two types of pathways for carrying the sensory system. I have just explained one of those. I have explained the spinothalamic tract, right, which crosses at the same level as it enters into the spinal cord. Another, I have discussed this one. Another one is this dorsal column medial lemniscal system. It is a more advanced system in which the special sensations, not just pain, touch, and temperature, the other sensations like proprioception, very fine touch, like the joint and position sensation, right, these sensations are carried through the dorsal column system. In dorsal column, I do not have the diagram of that with me, but in dorsal column, the neurons do not cross to the opposite side at the same level. The neurons cross to the opposite side at the level of uh, at the level of, it is written there, um, make their first synapse in the gracile or cuneate nucleus of the lower medulla. Means the posterior columns decussate at the level of lower medulla at the level of gracile and cuneate nuclei, right. So dorsal column and spinothalamic system, these are two systems which carry sensations. They carry different types of sensations. Here, spinothalamic tract or this system, it will carry touch, pain, and temperature, whereas dorsal column will carry joint position, joint sensation, position sensation, and it will also carry proprioception. And if you can remember, fine touch, here the touch is crude touch, right. So this is all about the sensory system, that how it is carried from the periphery to the central nervous system. Now the patient comes to you with the complaints of numbness, tingling, and or the other sensory complaints. How will you approach the patient? First of all, you will do primary sensory examination. How will you examine the primary senses? There are three primary senses mainly, which are, which are very much important for survival. First is the pain, second is the temperature, third is the touch, right? These two are the joint position and vibration are, these are kind of advanced sensations, although we have to check these also, these are very important to check. And even many a times you will understand the pathology only by checking the joint position and vibration sensing, but this is how we have to remember. We have to test for pain, we have to test for temperature, we have to test for touch, then we have to test for joint and position testing, then we have to test for vibration sense. Now one by one we will discuss all these. The sense of pain usually is tested with the clean pin, which is then discarded, right? We prick the pin. The patient is asked to close the eyes and focus on the pricking, right? Unpleasant quality of the stimulus, not just the pressure of touch sensation elicited, right? We will tell the patient to close the eyes and sense for the pain that is being produced by us. Areas of hypalgesia should be mapped by proceeding radially from the most hypalgesic site, right? This is how we have to proceed uh, with the examination of the painful area. Testing for temperature. All right, how do you test for temperature? The temperature sensation to both hot and cold is best tested with small containers filled with water of desired temperature, right? We will test this with the help of warm or cold water. Water is safe because we will know how much can we heat or how much can we cool down the water, and we will use that water for testing the particular sensation, right? Temperature sensation and I mean hot and cold sensation. An alternative way to test cold sensation is to touch a metal object. We can use metal object also, such as a tuning fork at room temperature, and we will touch that tuning fork to the skin. Then for testing warm temperatures, the tuning fork or other metal object may be held under warm water or desired temperature and then used, right? This is all about the examination. Then the appreciation of both cold and warm should be tested because different receptors respond to each, right? Testing for touch. Okay, testing for touch is usually tested with the wisp of cotton, minimizing the pressure on the skin. Very much understood. Patient is tested with the eyes closed and should respond as soon as the stimulus is perceived, indicating its location. Now, joint and position testing. It is a measure of proprioception. With the patient's eyes closed, joint position is tested in the distal interphalangeal joint of the great toe and the fingers, right? If errors are made, more proximal joints are tested. Very easy to understand. This is how we test for the joint position. Actually, we most of the times we use the great toe to touch. We will, we will hold the toe from the sides at the level of distal interphalangeal joint, and then we will move the dip, the distal phalanx, to the upper or the lower side, I mean to the superior or inferior side, and we will ask the patient that tell me whether I have moved your toe to the superior position or I have moved your toe to the inferior position. If he, if he replies correctly, if he responds correctly to your question, means he is not making an error. If he is making an error, he is telling you the wrong direction again and again, means his joint position sense is gone. Then you will test the more proximal joint, that what is the extent to which this joint position sense has gone. Then vibration sense testing. It is tested with an oscillating tuning fork that vibrates at 128 Hz. Vibration is tested over bony points beginning distally. If abnormalities are found, more proximal sites should be examined. Again, vibration sense. We use 120 Hz tuning fork. This is important because it is asked in exams many a times. You have to remember this 120 Hz tuning fork for vibration testing. Cortical sensation, this is kind of special sensation. Special, I mean to say, it is more advanced sensation. It is directly controlled by our cortex. Our cortex, cerebral cortex, is responsible for sensing these sensations, right? Touch localization is performed by light pressure for an instant with the examiner's fingertip or a wisp of cotton, right? First cortical sense is touch sensation. Touch is the first sensation. Touch localization, we will tell the patient to localize the touch where I have just touched. Then 2 point discrimination, the patient is able to discriminate between 2 points at 3 mm separation of points where on the fingertips. These the separation of points, the distance between 2 points, which the patient can appreciate as different, as two separate points, is different at different locations, right? For example, the patient can tell a difference of 3 mm at the fingertips, but he will not be able to tell a difference of 3 mm on the back of the, I mean, skin of the back, right? So the different areas of the body are differently sensitive. That is what I mean to say. Then graphesthesia. Graphesthesia is again sensed by cortex. We will draw something with the eyes of the patients closed. We will draw something on his back or on his palm, and we will tell the patient. We will ask the patient to tell that what I have drawn. If he responds correctly, means his graphesthesia is intact. If he is not able to respond correctly, means his graphesthesia is gone. I mean, his this cortical sensation is gone. Then stereognosis. Stereognosis is the ability to identify common objects by palpation, recognizing their shape, recognizing their texture, and recognizing their size. Common standard objects such as keys, paper clips, and coins are best used, right? Yes. Common standard objects such as keys, paper clips, and coins are best used. Common standard objects such as keys, paper clips, and coins are best used. Then we will do nerve conduction studies. We can do nerve biopsy if the condition of the patient is demanding these tests, right? If we are not able to, you know, uh, we are not able to assess that what is the cause of the loss of sensation, or sometimes we are not able to elicit the sensory loss. At that time it is very imperative to conduct nerve conduction studies. And sometimes if we suspect some infectious cause, or if we suspect some autoimmune cause, we can do nerve biopsy. Now you have done the examination and you came to a conclusion that okay, the patient is having some sensory loss. Now you have to localize the area of the nervous system which is responsible for that sensory loss. You have to, localize the structure of the nervous system, that what is damaged, which is resulting in this kind of sensory loss. What can be damaged? Nerve can be damaged, receptor can be damaged, skin can be damaged, right? Spinal cord may be defective, so there may be disease of spinal cord, some disease of spinal cord. There may be some brain disease, which is, for example, if the patient has stroke, if the patient has some demyelination in the brain, means the lesion can be anywhere. Now it is our duty to pinpoint that where is the lesion, right? This is known as localization of sensory abnormalities. First of all, if we suspect that the nerve or the nerve root is involved, then what we will find? We will find radicular lesion. Radicular lesions are accompanied by deep aching pain along the course of the nerve. Very important. For example, sciatica. Sciatica occurs when L5 or S1 root is compressed by ruptured intervertebral disc. It will cause sciatica. Sciatica is radicular pain which starts from the thigh, and it starts from the lower back, and it will reach up to the foot, or it will travel the thigh and the leg, and it will reach the foot, the sole of the foot, right? It is present throughout the course of the L5 and S1 distribution, right? L5 S1 compression will cause sciatica. When multiple mononeuropathies are there, I mean single nerves are in, not roots, but nerves are involved, right? Roots will combine to form trunks, and trunks will combine to form cords, and cords will give rise to nerves. So neuro we are discussing, this point is basically about neuropathy, I mean the involvement of the nerve in multiple neuropathies. Multiple mononeuropathies means different nerves in different localities. I mean, for example, if one nerve of thigh is involved, another nerve of leg is involved, another nerve of foot is involved. These are three different nerves, and they are involved. Then symptoms and signs occur in discrete territories supplied by different individual nerves. Right? It is very simple to understand. With polyneuropathies, sensory deficits are generally graded, distal, and symmetric in distribution. Right? When dysesthesias reach the knees, they usually also have appeared in the fingertips. Right? It is length dependent neuropathy. Length dependent. Length dependent. The process is nerve length dependent, and the deficit is often described as stocking and glove type of sensory loss. Then small fiber neuropathy, it occurs in diabetes mellitus. It is characterized by burning, painful dysesthesia with reduced pinprick and thermal sensation, but with sparing of proprioception, of course, because proprioception is carried by the large fibers, not small fibers. Proprioception, motor function, deep tender reflexes are carried out by large fibers and not by small fibers. Small fibers will give rise to burning, painful dysesthesias. Then large fiber polyneuropathy are characterized by vibration loss, position sense deficit, right, imbalance, absent tender reflexes, motor dysfunction, but cutaneous sensation like touch, pain, temperature will be preserved. So large fiber, small fiber. Then sensory neuronopathy or ganglionopathy. If ganglion is involved, ganglion will give rise to widespread but asymmetric sensory loss occurring in non-length dependent manner, so that it may occur proximally, it may occur distally, it may occur in the arms, it may occur in the legs, it may occur in the bones. So there is no particular pattern of involvement, but the damage is widespread, and you will be having symptoms very much vague, very much widespread. They will not be pertaining to, they cannot be localized to a single thing. So this is basically seen in ganglionopathy. Pain and numbness progress to sensory ataxia and impairment of all sensory modalities over time. Okay, very nice. So this was all about the localization of sensory abnormalities. Now we have localized to nerve and root. We have just discussed nerve and root. If nerve or root are involved, you will find these symptoms. If spinal cord is involved, then what will you find? If spinal cord is involved, you will find these symptoms on the basis of of the level of the injury, the type of the injury, whether spinal cord is compressed, whether spinal cord is transected, whether spinal cord is infected. I mean, different etiologies, different patterns of spinal cord involvement will cause different symptoms. For example, for example, if the spinal cord is transected, all sensation is lost. All sensation is lost below the level of transaction. Bladder and bowel function are also lost, right? If lateral hemisection of spinal cord occurs, it will produce Brown-Séquard syndrome. Now, what is Brown-Séquard syndrome? Brown-Séquard syndrome means there is loss of pain and temperature in the contralateral side, and loss of proprioception and power on the ipsilateral side. Right, it is all about remembering. You have to remember Brown Sequard syndrome. It is also known as hemicord syndrome. Here the half of the spinal cord is damaged. Right, the contralateral, on the contralateral side there will be absent pain and temperature. On the ipsilateral side there will be absent proprioception and touch, and fine touch, and proprioception, joint position sense loss. Right, there can be motor loss also. When all extremities are affected, the lesion is probably in the cervical region. When cervical cord is involved, all extremities, four limbs will be involved. Four of the four limbs will be involved. The presence of upper motor neuron signs support a central lesion. Right, if there is CNS lesion, I mean if there is brain lesion or this medulla or the upper part of spinal cord involved, it will be known as central lesion. A hyperesthetic band on the trunk may suggest the level of involvement. There will be a band, there will be a tightening sensation at some level in the trunk, in the upper, in the chest, in the trunk. I mean, depending on the level of the lesion at the spinal cord, you will be able to appreciate a band on the trunk. Very important. It is asked many a times in the practicals कि पट्टा कहाँ पे बंधा हुआ है, जो पट्टा बंधने वाली एक सेंसेशन है, that you will be able to appreciate in case of motor neuron lesion. Now, if the lesion is in brainstem is infamous for cross patterns of sensory disturbance. Means there will be sensory loss on one side and motor loss on the other side. For example, numbness in the face, on the in the right side of face, and left sided hemiparesis, which occurs in Weber syndrome or some these all the midbrain syndromes. Means there will be crossed pattern of sensory or motor disturbance. If thalamus is involved, there will be hemisensory disturbance with tingling numbness from head to foot in the, which is thalamic in origin. Right, occasionally if VPL nucleus is involved, there will be Dejerine-Roussy syndrome. Dejerine-Roussy syndrome means there will be burning sensation which the patient will complain, and it is severe burning sensation on the opposite side of the body, opposite one half of the body, in case of lesion of the ventroposterolateral nucleus of the thalamus. It occurs in strokes, thalamic strokes. Right, so this is all about the localization. Here we have discussed the brainstem, what are the lesions in the brainstem, and the symptoms of the lesions in the thalamus. Treatment depends on the underlying cause. Right, many a times you may have to support the patient, only supportive care is needed, because you cannot do much. For example, in complete hemicord section, you can do supportive care, you can do proper diet and all that stuff. Right, dysesthesia is when severe and persistent, they may respond to anticonvulsants, antidepressants. Right, when there is pain, neurological pain, you have to give anticonvulsants, carbamazepine, gabapentin, pregabalin, and antidepressants like amitriptyline, nortriptyline, desipramine, venlafaxine. So this is all about the treatment of the neuropathy. So we have discussed this whole of this chapter. We will revise it a little. They say कि it is numbness, tingling, and sensory loss, the name of the chapter. Positive and negative symptoms. Prototypical positive symptom is tingling, negative symptom is numbness. Right, sorry. Terminology, we have discussed paresthesia, dysesthesia, hyperesthesia, anesthesia, analgesia, hyperesthesia, allodynia, hyperalgesia, and hyperpathia. You must go through all these definitions again and again. Anatomy, there can be receptors, there can be spinal thalamic pathway, there is dorsal column, then there is the central nervous system. How will you approach the patient? We have to touch for the primary senses like pain, touch, temperature, joint position, and vibration sense. Then we have to then we have to look for the cortical sensations. These are four types of cortical sensations. Then you can do nerve conduction study, nerve biopsy. Then you have to localize the abnormalities, whether it is pertaining to nerve and root, whether it is pertaining to spinal cord, whether it is pertaining to brainstem. Brainstem is number 3. whether it is pertaining to thalamus. Treatment is supportive, and you can give anticonvulsants for neuropathic pain, or you can give antidepressants for neuropathic pain. So that is all about the symptoms of neuropathy, or these are the uh, certain special types of symptoms, I mean, with which the patient complains to the OPD many a times. So I hope you have learned a lot from this video. Thank you so much for your patient listening.